Good morning, good afternoon. I'm happy to be sitting here in Uganda with the fabulous fellows and ready to present on embolotherapy. Here's the team that I brought with me from Canada, who's just going out to lunch right now. So I've given a couple of lectures at this series before, so you may not remember me. So I'm from Oshawa, which is near Toronto in Ontario, Canada. And I thought before we got started into the science and the real learning, just to thank Road to IR and Health for the World for inviting me and including me in these great educational sessions. My team of Jesse and Andrea, nurse and tech from Toronto with me. How do I go to the next slide? All right. So I started to say, so just to give you a sense of what's going on, where I'm from. So this is Toronto. Canada, as you can see, is a pretty big country. Oh. All right, I think I've been muted. Can you hear me now? Oh, no, I had mine on. Can you guys hear me? All right. Yeah, because I've got mine. I left mine on.
Okay, sorry about all that. So here's Toronto and Canada, a pretty big country. How do I get this to me? Up on the screen.
So I actually live in
Oshawa, which is just east of Toronto.
Can you like
can you reach twice?
yeah.
Sorry? That better? All right, sorry, this is, I'm muted because I'm on. Yeah. All right, so, sorry. Here we go again. So just in terms of geography, so population of Oshawa, 400,000, population of Toronto, 2.8 million, population of Canada, 81 million compared to, I've chose Tanzania, almost 70 million, and yet Canada is 10 times as large as Tanzania. So we've got a pretty big country, but a relatively small population compared to Africa and other countries. Just a couple of pictures of Toronto. So the famous skyline, the CN Tower is a beautiful building. We've got some pretty bad traffic. This is one of the major highways in the city, yet our traffic kind of pales in comparison with what I've seen in Kampala. We've got a wide variety, beautiful country. So here's the Arctic Ocean up the northern aspect of the country. Here's a couple of beautiful glaciers. And we took a little plane visit up there. And that was wonderful to see the remoteness of the country. We have different animals than you, but we do have lots of exciting animals. We've got polar bears, moose, black bears and grizzly bears, and one of my favorite local birds is the woodpecker. You guys have pretty good beer here, the Nile beer. We've been enjoying that. But just in contrast, we have our own special beer. We have iceberg beer. And these are actually pictures from St. John, Newfoundland. And this is a common sighting. This is called Iceberg Alley. This is and you very commonly see very large. We're going to talk here a little bit. So we'll talk about some principles, various agents, clinical applications, particularly GI bleed, which is what Alex had initially asked me to talk about, and show a couple of cases. So just to start off with, here's some quiz questions, which we're not going to deal with now, but I just want you to think about them. And as we go through the talk, hopefully you can come up with some answers that you may or may not know. So 78-year-old man, bleeding gastric ulcer. So what would treatment options be? Endoscopic clipping, surgical oversewing, conservative management, medical watchful waiting, IR embolization, or all the above. Second case, 65-year-old woman with documented diverticular bleed. What would the embolic agent of choice be? Coils, PVA, embospheres, alcohol, or all the above. Case 3, 24-year-old woman, postpartum hemorrhage, treatment options,
All right, more technical problems here, sorry. You can hear me now. Yes, thank you. All right, so principles of embolization. So all right, more technical problems. So, so a therapeutic which in which blood vessels and vascular spaces are deliberately occluded by injecting material into them used image guidance. So principles really, how do you decide what agent to use? And that depends upon the size of the vessel to be occluded and the duration of occlusion desired. For large vessel occlusion, you often might use a mechanical device or arterial level. Typically, we would use a smaller agent, particularly the ideal embolic, be sterile, non-toxic, non-allergenic, inexpensive, widely available, pretty opaque, and easily delivered. I think we all know that we exactly have that. We do have a lot of really great agents and devices. We need to be very carefully about general principles and decide which device to use. There are a couple of things. So polyvinyl alcohol, the like the bits come inside. So these inside, depending upon what the treat is, it actually at the tone of are they fibroid with size particle. So it, 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 is yeah, All right. Sorry. Go back. I think we're back. Sorry about that. So embospheres is a trade name. So these are spherical particles that are made of a plastic, kind of like contact lenses. And these are nice because they're much more uniform. And although these particles are numbered in terms of, say, 300 to 500 microns, because of the shape of them, they're all sticky. They clump together. So they actually act as larger particles than that. Whereas the embospheres, which are similarly calibrated, act in a somewhat smaller way. So, for example, when I do a UFI, if I use PVA, I use 300 to 500 microns. And when I do a UFI with embospheres, I use 500 to 700. Metallic coils. So metallic coils come in a variety of shapes and sizes, with or without Dacron fibers. Gel foam, which you've heard about, I'm sure, and we will talk about shortly. Temporary agents, biodegradable. I mean, these are all kind of fancy things that I'm not sure how available they are. Not something I typically use, but autolycus blood clot. There's fancy ways you can actually take blood out of someone, let it clot on the table, and inject it back in. But the simple thing we do is, if you're doing a liver biopsy, for example, pull the needle out a little bit, pull the stylet, count to 20, and then some blood clot forms in the needle, and then you just plunge that back in. And that's a very simple and effective and inexpensive way to embolize a tract. Gelatin sponge can be used in a variety of ways, which we'll talk about shortly, and that's a great temporary biodegradable agent. And then these other fancy agents, angiostat and whatnot, which again are available. The thing to be important to know or to be aware of or to remember is that although the agent as such is temporary, for example, gel foam, gelatin sponge, there's an inflammatory reaction that occurs, so that even when the agent itself dissolves, the vessel may be permanently occluded. So, for example, I've done fibroid or uterine embolizations with gel foam, and then say come back 2 months or 2 years later, and the uterine arteries may be completely occluded. Permanent agents can be liquid form, absolute ethanol, glue, citral iodized oil like ethanol or lepidol, boiling contrast. It sounds pretty fancy. I mean, they talk about it, but I don't know that anyone really uses it. It's complicated to use and people could burn themselves. Or hypertonic glucose, not something, again, typically that we use. Permanent agents, we talked a bit about PVA before. There's also can be glass or plastic or metal microspheres. Mechanical devices, we talked a little bit before, coils, detachable balloons, and plugs. So here's just a picture of these plugs, which are really great because instead of using 2, 5, 10 coils, you can just use one plug. Now, these plugs are significantly more expensive than coils, but because you only use one, the length of time it takes to do the case is much reduced and the number of devices you use is reduced. So overall, these are very valuable. Having said that, in our practice, we don't use these. Detachable balloons, again, perhaps more used in the pulmonary AVM setting or the neuro setting, not something that I have used. Gelatin sponge is a very common, easily available, and inexpensive thing, typically available in sheets or powder. We usually use it in sheets, and you can then use it in 2 ways. You can cut it into cubes to make a slurry, or you can roll it like a cigar and make little torpedoes and inject one at a time. Gel foam powder is something I've never used because it's so small. Got to be careful because there is the risk of ischemia. Typically, you'd soak gel foam in contrast so that you can see it. And for certain, gel foam sponge in any way is difficult to inject through a microchip. So you need to think about all those things. So here's a typical sheet of gel foam. And what we can do then is cut it up into small little cubes and then put the cubes into a syringe. So say add the cubes to one syringe, 3-way stopcock, add contrast to the other syringe. And then as you would with PVA, you just mix them up back and forth and you kind of create a little slurry, and that's easily injected and quite effective. As I said, you can make a gel foam slurry, just cut this up into linear bits, then roll it up, and then you just kind of stuff it in the end of a syringe, add some saline or contrast, and then you just plunge that in. So as I alluded to before, mechanism of action is both mechanical obstruction of the vessel wall inflammation, and induction of thrombosis. As I said, gelatin does dissolve over several days and allows for recanalization, but not always, because the inflammatory result can lead to permanent occlusion. So typically gel foam would be used for trauma, postpartum hemorrhage, and for GI bleed if, say, you can't get exactly to the bleeding source. Either you can't see or you just can't get there. PVA particle size varies, so you need to think about the size depending on what you're trying to do. The smaller the size, the more ischemia there will be, and the smaller the size, the more shunting there will be. So you want a small size, say, for a hepatoma, which are very vascular tumors, but if the size is too small and there's too much shunting, you can actually shunt right through the hepatomas and get particles into the lungs. Usually mix it with contrast so you can see it, injected through a diagnostic catheter or a coaxial refresh microcatheter. And it does require thorough mixing. It aggregates, it jams the catheter. So there's a bit of technique to it, but these are great and very commonly used things. I mean, this is what I use in UFIs every day. So mechanism, again, incites inflammatory reaction with thrombosis and dense fibrotic connective tissue formation. Thrombus recanalization can occur over time, and typically you're not embolizing, say, for example, in the uterine arteries. You're not embolizing the uterine arteries, you're embolizing the uterus and the fibroids. So indications typically would be tumor embolization, uterine fibroid embolization, typically not used for GI bleed. They're small particles and they will cause end-organ ischemia. Coils, again, wide variety of shapes and sizes and types available. You choose it based on the vessel diameter, the flow rate, and the catheter size you're using. Sizing, you need to pay attention to the markers on the package. So they are sized according to the diameter of the coil, the length of the coil, and the diameter of the deployed coil. So usually there's a nice little diagram on the package to help you sort that out, because it might say 14 by 6 by 8. And without the diagram, it's hard to know which of those numbers corresponds with each of these things. So here's just a picture of a kind of an interestingly shaped coil. And again, they design little different shapes, theoretically have different advantages in different vessels. I think the main advantage of a coil, or a coil that works the best, is these coils with these Dacron fibers, which really help incite thrombosis and then occlusion. Coils that are just bare metal coils will really just result in mechanical occlusion only, and you require many more of them, and they typically work a little less well. Again, a different shape of a metallic coil. So as the coils come in different size. So in the old days, we used to use 038. Now, depending on what vessel you're in, say a splenic artery, you might use a 035 system. If you're using microcatheter, then you may use 025 or an L18. Stainless steel coils have a lot of MR artifact and usually are to be avoided, again, depending upon what part of the body you're working in. Platinum microcoils are great. You can see them really well. Very often these microcoils don't have Dacron fibers, and you need to pack a lot of them in, to get good occlusion. So mechanism of action is, say, direct physical occlusion of the vessel, and then thrombogenic adherence. So they're introduced into a catheter either with a guide wire or a coil pusher, or depending on where you are, sometimes you can just blast it in with an injection of contrast. So you load it into the catheter and then take a 3 cc syringe or a 1 cc syringe and just blast it in, and it's nice. It's kind of cool to watch it flow into where you want it to go. But there's, of course, much less control over it because you just have one shot at it and it goes where it wants. Risk of migration is always important to keep in mind. So you need to size coils very carefully. If they're too small, they'll go where you don't want. And very often the problem is you say, oh, it looks pretty good, but I'm going to put one more coil in. And that one more coil then pushes the catheter back, backs up, and goes into a vessel that you don't want to occlude. So if and when that occurs, you can retrieve them with snares. That can be a little bit challenging. So I'll get into that. So here's just kind of a picture. You've got your guiding catheter, uterine catheter. And then you're kind of pushing and deploying and observing, and then you create this little nest. And by packing the nest together, you get a great mechanical occlusion. Detachable coils came along a few years ago, and they're really great. There are many different designs. If you can see this as this kind of little locking mechanism, so that if you deploy the coil and say it migrates or it doesn't go where you want, or it doesn't look how you want, you can always retrieve it and pull it out, reposition it, or put a new catheter in of a different size. So these are really nice. We don't use them all the time, but we use them in challenging scenarios where we're worried about a complication or we're not sure where we're getting. So typical indications for coils, varicoceles, aneurysms, pulmonary AVMs. Ethanol is a great agent. It's pretty powerful and it works very well, but really used in, I think, my practice, at least fairly limited scenarios. So it causes direct tissue necrosis with vascular occlusion and stasis. It's highly toxic. It causes severe pain if and when it leaks into any other tissue other than your target tissue. It's nice to be able to see it because it is essentially radiolucent. If you want to see it by adding iodinated contrast to it, you're going to dilute it and not get the same effect. So you could mix it with contrast powder. For chemoembolization, it's mixed with lipiodol, and that allows you to see it. Depending on what you're aiming to occlude, say, for example, you want to occlude a kidney for hypertension or occlude the vessel going to a renal cell carcinoma, we often would use a balloon occlusion catheter to prevent alcohol reflux into a different vessel. Over time. Indication typically tumor ablation, vascular malformations. So glue is something that I think is a bit challenging to use. You need to have a lot of good experience with it. Again, not something that I've used. There are a number of our people, my partners, use it on a regular basis and are familiar with it. So this is essentially crazy glue. It's the same stuff you buy at the drugstore. It just costs more because it's got a medical label on it. Mix it with contrast powder so you can see what's going on. Administered through coaxial catheters, and typically use this for AVM. So this is a great product, but I've certainly seen a number of complications, including microcatheters being glued into intracerebral vessels because the glue hardens and the catheter breaks off. Complications. So the complications start off with the basic puncture site complications and complications related to general angiography, which you guys know about. And then the specific complications related to embolization. And to some degree, it depends on what kind of particle you're using. So if you're using a liquid agent or a small particle, you can get nerve injuries or skin sloughing or bowel ischemia. When you embolize an organ to the extent of necrosis, you can get secondary infection, for example, in the spleen, liver, or kidney. So we usually give prophylactic antibiotics in those cases to reduce that risk. Post-embolization syndrome is common and pretty universal. And like other things in life, is variable in terms of severity and length in different patients. So as a result of ischemia, there's capsular distension from edema, and so that causes pain. Then you get fever and nausea and leukocytosis, which begins probably 8 to 12 hours after embolization and may last 3 to 5 days. Now, you may see gas in the target organ, which could be related to necrosis, and it can be difficult to differentiate between just necrotic tissue gas and secondary infection. So you need to look carefully, do they really have a fever? Do they have a white count? And decide whether or not to give antibiotics or just watch or potentially to percutaneously drain. So here's one example. Here's an artifact you can see from one of my partners just did this recently, post hip arthroplasty. So afterwards, they were bleeding, they're having swelling. So this angiogram was done from the contralateral side. See the femoral artery. And here you can see an AV fistula. So here's early filling of the femoral vein. So, the image isn't coming up. What it was supposed to show was, so he embolized this with a coil. Maybe you can see this. And then actually he lost one of the coils and it migrated somewhere else and he went back and fished it out. Because with an AV fistula, there's high flow, a big connection, and you don't have a lot of landing room. So it's easy to have the coil fly through the connection, the communication. Here's a woman who presented with chest pain after undergoing pelvic ovarian vein embolization. So because the direction of flow is towards the heart and the vessels get larger towards the heart, these things do migrate. So you need to be very careful about selecting the appropriate size of coil to reduce that risk. So overall clinical applications of embolization: uncontrolled hemorrhage, GI bleed, hemoptysis, postpartum hemorrhage, trauma, hemorrhagic neoplasms. You can have primary therapy for AVMs or aneurysms. You can use this for hepatic, bland, or chemoembolization, hypersplenism to reduce splenic volume, uterine fibroids, and as I just mentioned, gonadal, ovarian vein, or gonadal vein varicocele embolization. We do use it at times, and it depends a bit on your surgeons and your surgical program, for preoperative devascularization. If you've got a very large renal cell carcinoma or a vascular metastasis, bony metastasis, or sarcomas, anything that's wildly vascular, it's really helpful to the surgeons to make their operation easy, to reduce blood loss by preoperatively devascularizing these things. And typically for that, you'd use fairly small particles, keeping in mind AV shunting or potentially alcohol. All right, so here's a case related to GI bleeding. So 60-year-old man, blood per rectum and melena stools. So now, what do you want to know next? What do you want to ask the surgeon or the attending physician to help guide your treatment? So I would normally ask you these questions, but I'm just going to give you the answers. So how stable is the patient? What's their heart rate? What's their blood pressure? What's their coagulation status? Are they anticoagulated? Is their INR 5.5? How many units have been transfused? And then what test would you do next? So depending upon the answer of that, if they're clinically stable, the coagulation, say they're anticoagulated, and maybe they've had 1 unit of blood transfusion, then I'd say, why don't we just watch and wait, withhold anticoags if you can, and just keep on watching, and very often bleeding will stop. So if it doesn't stop, what test would you do next? CTA is the correct answer, yes. But before we get to a CTA, you want to get other specialists involved. You want to have a gastroenterologist or a surgeon involved, because endoscopy, I think, is really the primary mode of treatment for GI bleed. So this can be both diagnostic, where's the bleeding from, and therapeutic. They can endoscopically treat these things. And then key, as Alex just mentioned, is a triphasic CT. So you're looking at an unenhanced CT, arterial phase, and then a venous and or even a delayed phase. Not only to look for vascular extravasation, but to look for vascular anatomy. Do they have replaced right hepatic artery? Do they have iliac artery occlusion, which may complicate or make percutaneous access impossible? Nuclear medicine is, I think, a pretty good test, and we sometimes recommend it just to kill time. It's quite sensitive and very often doesn't really give you a definite bleeding site. All right, so here's that case again. So here's a CT angiogram that was performed. So you're looking for contrast in the wrong place, and over time, you're looking for contrast to pool somewhere. So just to give you the answer, so here's contrast pooling in the bowel. So now we have a target. So now we're going to get in with a selective catheter into the SMA. And now you can see contrast extravasation in the kind of ileocolic branch here. And then we would get into that with a microcatheter and then place. So for this, typically coils would be the thing if you get close enough to block off that vessel. So these aren't related properly. Should be like figures? Like, no, they're like, this doesn't correspond with it. So these are different words with the same picture. All right, so here's another case. So here's some contrast extravasation again. So you can see they get far, far, far in with the microcatheter. You can see contrast extravasation, and then you would drop a couple of coils in. And typically these are small vessels, fairly low flow. And so usually you can easily treat this with pretty small coil. You need small coils and only relatively few of them. Uterine fibroids, common cause of dysfunctional uterine bleeding. So although ultrasound is widely available and widely performed, we usually insist on gadolinium enhanced MR. It really helps define the appearance of the fibroids. Sometimes fibroids spontaneously necrose, so you can't kill a dead fibroid. And so these are really helpful for us in terms of decision making. And it's important for the reporting radiologist to accurately describe the size and location of each fibroid. So say, for example, if someone comes to you with heavy menstrual bleeding and she's got a 4-centimeter subserosal fibroid, that's not the cause of her bleeding. So it's important to keep these things in mind to help plan when to treat and how to treat. Here's just an article from 10 years ago now that I was involved with in Toronto, one of the first large center collaborative studies we did with the gynecology department. And essentially they had agreed, and this has become pretty much the standard of practice, that uterine fibroid embolization is essentially the first line of treatment when appropriate based on imaging and symptoms for patients with symptomatic uterine fibroids. So here's a typical case. Uterine artery always looks like this, pretty easy to identify. So this was done just with a standard catheter. I typically now prefer microcatheters. And so you see this big, huge vascular fibroid. So my typical embolic agent will be PVA 300 to 500. And then you're looking for stasis. Again, everyone's got a different idea of stasis, but you just inject and you watch this, and the kind of number people look at is 5 heartbeats. If this fails to clear in about 5 heartbeats, then you've done your job. So you don't have to occlude these vessels. You're not aiming to occlude the main uterine artery. You're aiming to devascularize the fibroid. So here's just a number of MR sequential images. And this is one of the nice reasons for doing MR, because it's reproducible, it's easy to remeasure. So here's baseline, a big fibroid, 3 months later, 1 year later, and then 4 years later, the fibroid is essentially gone. So this can be an incredibly effective treatment. This case perhaps isn't exactly the standard case. I always tell my patients, I'm going to make your symptoms better, but this procedure doesn't cure fibroids. It typically doesn't make them completely go away. It just makes them smaller. Postpartum hemorrhage. So we did a study in Toronto, retrospective analysis. Again, just briefly, embolization is the way to go, not open surgical treatment for postpartum hemorrhage. I think for the sake of time, let's just jump ahead here. All right, so let's go back to our quiz. All right, so 70-year-old man with bleeding ulcer. So what would the treatment option be? Alex, I can kick in.
So, bleeding ulcer, 78-year-old man, I think it depends on the status of the patient, hemodynamic status of the patient. So from what you mentioned, sometimes it can stop bleeding. You could, option 3 could be a stud, but all of them seem right. So I think I'll go for all the above.
All the above is correct, exactly. So the endoscopists are great at clipping these things. It's fairly unusual in 2024 that a surgeon would go in and oversew it. And conservative management, so treatment of medical management of peptic ulcer disease, fluid replacement, maybe a blood transfusion, watchful waiting, and many of these things will get better by themselves. And if they don't, often these patients come from GI, so they're typically going to have a go at it first. And if those things don't work, then IR embolization is a great choice. All right, 65-year-old documented diverticular bleed. Embolic agent of choice would be Sound.
Coils.
Coils is correct. So I showed you a couple of cases, and coils are effective and simple and work very well. Case 3, so postpartum hemorrhage. How would you best treat that? Surgeons commonly go in there and surgically ligate the internal arteries, which then radiologists could do bilateral coil embolization of the internal iliacs. Or you could do a particle embolization, uterine artery embolization. Eva? Number 2 is correct. So there's such robust pelvic arterial collaterals that if you tie off or embolize the internal iliac arteries, you're unlikely to stop the bleeding. And now you've kind of trapped yourself so that you don't have the opportunity to do the right thing, which is uterine artery embolization. All right, so I'm sorry for all those technical issues. That was a pretty quick run through. If anyone has any questions or comments, we've got a few moments. All right. Everyone enjoy the rest of your day.